My name is Jim Heath. I'm the president of the Institute of Systems Biology here in Seattle, and I'm also the director of the Pacific Northwest Hub of the National Recover Program on Long COVID. I'm joined here today by my co-investigator, co-director of the study, Dr. Jason Goldman from Swedish Providence here in Seattle. And I'm also joined by Whitney Gibb, who's a patient advocate and a long COVID sufferer, who's going to talk to you a little bit about what her journey's been like. I want to make a very warm welcome to study participants who have been involved in the Recover program and to any other members of the long COVID community who are watching this webinar. So the agenda is, first, I'm going to talk a little bit about what's coming. So I think we've had a few of these webinars. Probably many of you have not heard them, but Recover 1.0, the first version of Recover, ended last fall. And Recover Cycle 2 is going to pick up again in May and will recruit from patients that participated in Recover 1.0. And I'll talk a little bit about the objectives of that study, just a few slides, and then I'll pivot to Jason, who will talk about neurocognitive issues with Recover. And then Jason will hand the microphone off to Whitney, who will tell us about her journey, and then we'll have Q&A at the end of this. So for Recover Cycle 1, which started back in 2021, I think the first patients recruited into our consortium were early 2022. The major question we were trying to ask is, what is long COVID? And this was asked, of course, across the nation. And we ended up enrolling about 15,000 adult participants into the adult branch of the study. There was also a pediatric branch and an autopsy branch. It was an observational study that collected everything from blood to questionnaires to a couple of different tiers of clinical tests, depending upon the different participant and their symptoms and what they qualified for. And it was really designed to help us start getting a grip onto what long COVID and basically post-acute sequelae from infection is. And the mechanistic studies that have come out of that to try to get us more of a molecular picture of long COVID are really just now taking place. So the next slide. For Recover Cycle 2, one observation that was made pretty clearly in Cycle 1 is that for many of the participants in Cycle 1 that were suffering from long COVID, their disease trajectory did not necessarily resolve. It was evolving. And in fact, there's biological reasons to believe that that evolution may continue. Perhaps some people will get better, and perhaps there will be, and of course that does happen, but perhaps there will be some very long-term consequences of COVID that we have not yet begun to understand. And so with a pretty limited budget compared to Cycle 1, and based upon our experiences with Cycle 1, the types of testing that we want to do in Cycle 2 are illustrated here. The electrocardiogram, there's an NIH toolbox, which has to do with questionnaires and a certain amount of blood testing, things like this. There's a 6-minute walk tests. There's a smell test, and there's a complete neurocognitive testing, which is actually pretty extensive, that will happen in 2.0. Next slide. So the reason to focus on these subset of types of analyses that we'll do on participants is because what we learned in Recover Cycle 1 is allowing us to design what we call a kind of a nested control study. In other words, we're trying to understand different long COVID symptomologies that are seen across the patient population. And these range from neurocognitive, cardiopulmonary, and infection-associated chronic conditions, which can be some of the common features are chronic fatigue and things like this. So the key question is, try to capture these long-term disease trajectories and try to understand if and when emerging complications may actually emerge. And so the focus is not going to be just on all patients with long COVID, but on patients that have symptomology associated with these three conditions. And the size of the study, instead of being 15,000, is going to be 5,000 participants, but they will be drawn from the initial COVID group, initial recover group. Next slide. So any study like this, you want to have a sort of well-defined set of specific aims and hypotheses that underlie those aims. So one specific aim is to determine the long-term trajectories of neurocognitive, cardiopulmonary, and the ME/CFS subphenotypes. And the goal here is, can we understand initially the clinical and demographic factors that lead to persistent versus waning symptoms in these individuals, and provide preliminary data for intervention. So a big part of Recover 2.0 is going to be clinical trials that we don't yet know the details of those clinical trials, but that we will be executing alongside the observational study. And then the third specific aim on the next slide is to evaluate associations between new onset chronic conditions with and long COVID with neurocognitive, cardiopulmonary, and the long COVID other conditions subphenotype. So for example, new onset neurodegenerative disease. We hope we don't see much of that, but we know, for example, that certain neurological conditions are associated with, for example, Epstein-Barr virus. And Epstein-Barr virus can be reactivated during COVID infection. So the chance that this kind of thing will happen. Cardiometabolic disease. There's now an established connection between autoimmune disease that we're beginning to understand a little bit better. And so our hope is that we will begin to have a better understanding of these long-term associations. And of course, we're continuing to collect, I think, only two biospecimen collections during this cycle 2 study. But we have a vast biobank from cycle 1. And so what we learned from cycle 1 will help us understand the trajectories that we're getting out of the cycle 2 study. And I think that's my last slide. With that, I'll pass it on to Jason.
Thanks so much, Jim. I'm going to focus just a couple minutes on talking about one of the three long COVID syndromes that's going to be studied during Recover Cycle 2. This is neurocognitive dysfunction or neurocognitive symptoms. In lay terms, a lot of people are referring to this as brain fog, but there's actually a lot of different manifestations. And these are slides that I borrowed from a neuropsychologist named Jackie Becker, who presented at the Cycle 2 investigator meeting. She talked a lot about the discrepancies between subjective and objective findings. So for those who participated in Recover Cycle 1, you might remember some neurocognitive assessments that were being done. Some were just questions in a questionnaire. Others were, formalized exams assessing different domains of cognition, word finding, memory, attention, etc. And what we've noticed is some discrepancy between what people are experiencing, their lived experience, and what they're measuring on some of these assessment tools. So next slide. I like this cartoon that she provided. Our assessment tools in a research study are standardized, and they are kind of benchmarked against normative populations. So I like this cartoon where it's showing this scientist sitting at the desk and talking to a bunch of different animals who are all obviously very different, and talking about a fair test to climb up that tree. And it's obvious, right, that the monkey is going to be able to do that job best. But these types of tests are a little bit in the same way. They don't measure our differences from our baseline very well. They measure how we are performing a certain task of memory or attention, compared to a population mean. So I think these are not perfect tests by any means, but these are some of the things that people who participate in Recover Cycle 2 are going to be asked to take some of these neurocognitive tests to test, how good is attention or memory or language or reading comprehension. These sort of batteries help us on a population level define, where people are in their disease process or their disease journey. Next slide, please. So this is how it was done in Recover 1.0. We did a kind of a triggered succession of testing. So there was just questionnaires for everybody. And if people were reporting problems with thinking or brain fog, they did the next test, which is this NeuroQOL, or quality of life. And that assessed some, certain things. And if there was a low score there, it went to the next test, which was the NIH toolbox. And then if a low score there, the next test, the neurocognitive battery. In Recover Cycle 2, everyone's going to be doing the neurocognitive battery. And that kind of has to do with us thinking that this is a better test despite its, flaws. It's better than this kind of triggered or, sequential approach scientifically. And, that will give us a chance to, assess how people are doing neurocognitively in everyone who's joining the study. And next slide, please. And we think that's important because neurocognitive impairment or neurocognitive symptoms are really a feature that is one of the most common things that people are reporting in long COVID. So this little histogram here is the problems people are experiencing who took the NIH toolbox test. And in the whole of Recover, 64% of people were experiencing brain fog. So really, really common among those who had a long COVID. More than half were experiencing some of these symptoms. And then these are the different domains that the testing might try to get at. The table at the bottom, I'm not going to go into detail there, but just an interesting finding from one of the Recover papers that smell problems seemed to be associated with the neurocognitive dysfunction. So that link will also be explored. Next slide. There's a bunch of other questions that will be asked of the data that's collected in the Recover Cycle 2. And here are some of these questions. Does SARS-CoV-2 cause transient dysfunction of cognition or more long-term injury to the brain? Are neurocognitive symptoms mediated by another process like a cardiopulmonary disease or autonomic dysfunction? What is the trajectory of symptoms and resolution? Are patients with long COVID who are experiencing cognitive symptoms at risk for neurodegeneration? So that could be a longer term problem versus do the symptoms resolve? And how to best assess brain fog and capture the lived experience, as we're sort of, utilizing this questionnaire data, which is a more structured approach. So this is sort of one domain that I want to just highlight at tonight's town hall. I think we'll hear, more in a little bit from Whitney about some of her lived experience and some of the neurocognitive symptoms that she's experienced. And there'll also be, within Recover Cycle 2, similar approaches to trying to understand cardiopulmonary issues like shortness of breath and other problems of the heart and the lungs. And ME/CFS, so the fatigue syndromes that people experience after infection-associated chronic conditions. Next slide, please. And I also wanted to give a brief update about clinical trials. We talked last time on our town hall back in November about two really exciting trials. I've put the little logos for them there. It's Address LC and Reverse LC. Address LC, for those who weren't there, it's a trial of an experimental medicine that works on inflammation in the central nervous system, so kind of brain inflammation. It's sponsored by a pharmaceutical company named BioVie, and it's funded by the Department of Defense. And I wanted to give an update that this trial is closing soon. We anticipate probably only a few more weeks of enrollment. Reverse LC is the other study. It's a study of baricitinib, and that's a generalized immune modulator. So it tamps down inflammation. And this is part of the RECOVER program, and it's funded by the National Institutes of Health. Something new that I wanted to announce is we've formed this long COVID registry, and the QR code is there. So you can sign up for that if you'd like to be alerted to when these trials come around, and if you'd like to be considered for participation, I'd encourage you to sign up for that link. You'll see that it gives you a patient information sheet about what we'll do with your information, which is essentially just contact you when we think that there's a trial that you might fit in for. So that's all I had tonight, and I wanted to pass it off to Whitney Gibb, who's a patient who is living with long COVID, and she's going to tell us about her experiences and journey with the disease. So thanks so much for joining us, Whitney.
Thank you. My name is Whitney, and I'm honored to be asked to share my patient testimony today. Thank you so much for having me, and thank you to my family and friends that are also on right now, and some of them in the Seattle area. So I met Dr. Goldman and Ashley in Nashville at Vanderbilt back in December when they were doing research for the reverse long COVID study. And I shared this testimony in person there. And I was honored that they asked me to share it here on the town hall. So next slide. I just wanted to kind of walk you through my long COVID and vaccine injury journey, and what my life was like before COVID and after COVID. And I'll focus a little bit more on the cognitive, since we've addressed it in this town hall. So before COVID, this is me. I was 34. That was July 2020 before I got COVID for the first time. My helpful companion there, Little Bear, who's 14, has been with me through it all. But I live in Nashville, which is where I met Dr. Goldman at Vanderbilt. I am a long COVID vaccine injury patient there, and I have been since 2021. I have 2 bachelor's degrees from Miami University in Ohio. Before this, I was very active in my physical activity, my community, and my social life. And I began my career in medical devices at 24. Helping to train neurosurgeons on a spinal procedure. Next slide, please. I first got COVID in July of 2020. I tested positive for 5 weeks, and probably a lot of the same symptoms as a lot of you all on this call. I was mostly bedridden. I would take walks and bike rides outside to get some sun. But I had weakness, fatigue, memory loss, shortness of breath, and I developed COVID rash not once, but twice. So since then, I've had COVID 4 times, but none have been like my 2020 version, mostly just a bad cold, other than when I had a sinus infection and flu at the same time. That was horrible. But in April of 21, I rushed to get the vaccine. I did not want to suffer like I did in July of 2020 ever again. And I thought it would help me. So I did not know that it would change my life forever, along with long COVID. Next slide, please. So for about 6 months, especially after I got the vaccine, I was suffering and I did not know where to go. I didn't have anyone to talk to about it because I felt like no one understood what I was going through. But I experienced a lot of different symptoms and I felt really helpless. So I included this slide because when I went to go search long COVID or vaccine injury on the internet, I couldn't find anything. And so I included this slide just to show you a little bit about like how it felt when I went to search something. I could not find a thing. So I later came to learn that it had been blocked from a lot of social media outlets, which is why I couldn't find anything on it. But during those 6 months, it was a really trying time. And I felt so bad that, sometimes I questioned wanting to go on because I didn't think life was worth it at that point, going through the suffering and not knowing what was wrong or how to fix it. Next slide, please. So my life after COVID, I again waited 6 months. After those 6 months, I got into the long COVID group at Vanderbilt in Nashville. I think my dad had found it online. Luckily, it was in my backyard. But there are people from all over the world that joined that group and finally got some tests done and started to get some answers. But during that time, I had felt extreme fatigue. I was taking up to 3 naps a day while holding a full-time job. I had short-term memory loss, shortness of breath, hair loss, post-exertion malaise, which I found out is also common with long COVID patients. But sometimes I, do a normal workout and I would have to rest for up to 3 days after that because I was just so exhausted from it. Gained 10 pounds of inflammation. I had leg tingles, GI issues, brain fog. Sometimes my lungs felt like they were on fire. I would pant from just walking up my stairs or going on a dog walk in my neighborhood. And then probably the worst example that I have, during that time, I had a full-time job with a medical company. I flew to Wilmington, North Carolina for a work meeting. And when I came back from that meeting, I was supposed to give that company I met with quotes from our company to see if we could win their business. So they called me 2 weeks later and they said, Whitney, where are my quotes? And I had no idea who they were. I remembered I was in Wilmington, but I didn't remember the company's name to even Google them. I hadn't taken great notes during the meeting, and of what notes I did take, I think I lost them. And so I had to go to my company and act like we just lost the bid because I was so embarrassed that I couldn't even remember who these people were. Another example, during that time, I came back from a work trip and I walked around the airport 2 hours trying to find my car and where I parked. And when I finally got to it, 2 hours later, I didn't know where I put my keys and I had lost my keys. So I had literally had to get my car towed out of the BNA airport. I also fell asleep on the freeway 2 times. And, I was, say it lightly, I was struggling. So from 21 to 24, there's about 3 years, I still felt really, really crappy. And I almost felt like I was getting robbed of my normal everyday life. And for those 3 years, I went through lots of testing, lots of doctor's appointments, lots of therapies. I probably spent, I don't know, I want to ballpark it, but like 20-ish grand on treatments, and I bought books. I bought anything I could to try to get better. Got IVs, had people come to my house, and anyway, so during that time, I was diagnosed with depression, obviously, cognitive impairment, which actually took 3 years to figure out. But I did do 4 hours of the cognitive testing, and was diagnosed with delayed executive function, and my processing speed was not up to par. I had memory loss, got an autoimmune disease called Hashimoto's, fatty liver disease, my lung function had dropped, chronic fatigue syndrome, PMDD, dysthymia, my ADHD got a lot worse, suicidal thoughts, trouble sitting still, remembering plans, and then projects with a lot of detail would give me task paralysis, making most of my admin work overdue. And then my sentences would be out of order. So the next day I, would read something and I couldn't believe I wrote it because the sentence was out of order. Like the words in the sentence were out of order. Eventually I did lose a job with my medical advice company that I really loved that job. But I did lose a job. So in fall of 2024 is when I finally started to feel a little bit better. And I would say about 80% better. And then next slide, please. So I did a couple rounds of cognitive therapy. And this was not until I believe 2024, 23 or 24. But I had a lot of trouble, obviously, like remembering things, especially short term. I'd have conversations with people and not remember. I'd meet people and not remember them. And I had a lot of trouble staying on task. I had a lot of anxiety. I would get overwhelmed a lot. And so this is what my life turned into. So, if you look at some of the images, it's like, I can't even believe that was my life or my brain, given what I had done prior to this. But I did play a lot of brain games like New York Times crossword puzzles. I got Babbel to learn Spanish, and I do think some of that stuff did end up helping, as well as the cognitive therapy. Next slide, please. So my life now, one of the words I've had to learn is acceptance. And we learned that in our long COVID support group, which is no longer, unfortunately, but acceptance is a big thing I had to learn in my life because this was my new normal. And these are just some pictures with some of my doctors, my lung therapist, pulmonologist, and long COVID support group, labs all the time. And yeah, so this is my life now. And I feel like I'm one of the lucky ones. So next slide, please. Although I still do have trouble with things like memory, remembering plans or details, names, meeting people, events that happened, where I parked. And we did go over some of these things in cognitive therapy, but I do still struggle with it, just not as awful as I used to. Functioning speed, a lot of things that used to take me about 30 minutes will take me 3 hours, and honestly up to 6 hours, doing little tasks like making an Instagram reel or doing my expenses. Anything with a lot of detail or a lot of information, it just feels like overwhelming, and it feels like overload. Even this presentation, it shouldn't have taken me as long as it did. So I do still have like task paralysis where you just kind of shut down and then you procrastinate to do it at the very last minute. I still have troubles with the chronic fatigue, etc. You can see. Next slide, please. There was something that also happened, I would say fairly recently, but I was scrolling through my social media and someone had gotten engaged, and it was a guy, and I liked it because obviously I'm happy for them they got engaged, but I was like, why do I follow this person? And so I clicked on his profile and I had no idea who he was. So I clicked on our messages, and it turns out that we had been on multiple dates, and I had met his friends and everything, and I have zero recollection of ever even meeting that person. So that's just kind of how bad the cognitive stuff can get and got for me. So I do still struggle with some of that. Here's a couple of quotes that I asked one of my best friends and my dad to just to weigh in on for my presentation. But I'll just read my friends. Whitney used to be an Energizer bunny, but after COVID and the vaccine, I lost my friend as I knew her. Her personality disappeared. I didn't understand and I was frustrated. I thought we were growing apart. She would get anxiety and shut down, forget our plans, constantly be late. But eventually it got a little better. I had to learn how to adjust over the years. For example, I can send one-line text, not a full paragraph. And then one of the things that stands out from my dad's quote is just, I would always tell people, you don't understand, because while I'm sure some of you on this call have face the same struggle, you still look the exact same on the outside, but your brain and inside your body can be a lot different. And so that was one of the things, and still is one of the things, that I feel like people just don't understand. But if you could see inside of me, it is not the same anymore. But again, I do feel like I'm one of the lucky ones because we have doctors such as you all leading research, and we're so lucky to have you guys. I would truly not be here without people like you. So next slide, please. Now, here's one of the pictures. Last year, I'm still able to do things. There are people in my group that are not able to, that have PhDs, that are attorneys. So I do feel very grateful, but it is because of doctors and a lot of hard work from them and from me, and just a commitment to try to get better. So I was released from my pulmonologist in the fall, 4.5 years later. Just got an award for doing work in my community. I now work as a pharmaceutical rep because I lost my job as a device rep, I think 13 years in, 13 years later. So now I'm in pharma, which has changed. I am now active and I can exercise again. Sometimes things cognitively take me a lot longer to do, or I have different ways of doing things like note taking and calendars and things like that, but I can still do it. So I do feel lucky.
Thank you so much, Whitney, for sharing that story. I think it takes a lot of courage to talk about what you've been through, and share some of those anecdotes that I'm sure were just really hard and traumatizing for you to experience all those things. So we really we respect your courage and just bringing your story here to share with others. I think one thing that I've admired of your approach is you're networking with a lot of people, you're working with other groups, and you're doing this, I think, from what you told me, to kind of help other people by sharing your story. So so we thank you for that. We really do.
Yeah, thank you. And ditto, Whitney. I really appreciate you coming on and telling us this story. I think one thing that certainly Jason and I I've learned over the past few years, is at all the meetings that we've had on long COVID, we've had advocates such as yourself come and talk to us, and it has a tremendous focusing effect because, I think in many ways the medical community has not seen people like you before.
Mm-hmm.
And yet, now I'm hoping that in the next few years we'll actually make real progress on this. I think all we've really done so far is to say, yes, this is a condition, and begin to define it pretty well. But there's little signals now that there are some genetic underpinnings for some of the sequelae. We're having indirect measures of that I think will ultimately lead to some diagnostics, but all the normal medical tools still don't work. It's actually remarkable.
Mm-hmm.
A tough situation.
And it can feel, as a patient, it can feel very isolating, or like people don't understand, which causes a lot of depression and just feelings of helplessness, because some people don't know how to get better, and not every patient's the same with their journey either. There are so many different symptoms.
Yeah, that's absolutely true. It's that famous quote from Tolstoy, all unhappy families are unhappy in their own way. That's the diversity of different patient journeys with long COVID is almost as broad as the numbers of patients.
Yeah. And I think that also, even though there are, it's been reported more than 200 symptoms associated with long COVID, and there's probably more. Um, but there are some real commonalities, some things that are shared by a lot of people who are suffering from long COVID. And I think, what you just shared with us, Whitney, does kind of speak to that idea. I mean, you had a lot of the hallmark symptoms. Some of the confusion and memory loss that you were experiencing is, what we are calling neurocognitive symptoms, or brain fog in the common parlance. You were experiencing the fatigue, and you talked about, having to recover from an easy workout that, would have been nothing before your first COVID infection. And getting rid of your Peloton, and, all these kind of anecdotes kind of speak to that multi-symptom nature of this disorder. So, what has been the kind of most life-changing of all these multitude of symptoms? What is the symptom that you've found maybe in the past and now are the things that are most slowing you down and that you've most had to adjust to? You talk about accommodating.
I think that the one most slowing me down is like the chronic fatigue, because I do believe if I wasn't as tired all the time, I probably could remember a little bit more, and I probably could do a little more activity. But the chronic fatigue has not gone away. It's gotten better, but I also now am on. I have a prescription for 40 milligrams of Adderall a day, as opposed to life before COVID. I didn't take any Adderall, or if I did, it was 5 milligrams. So the fact that it's gone up that much just to keep me awake is a little insane. But again, I told you, like, I fell asleep on the freeway twice. So that's probably been the most
Scary.
debilitating, as well as the cognitive stuff. Like, the cognitive stuff I find is somewhat embarrassing, because I look normal, but nobody knows that it's changed.
Yeah. Yeah,
So
and you're obvious. Oh, go ahead, Jim.
yeah, you probably don't have a good answer because you've done so many things. You've been very active about trying to find ways to get better. Do you think there's any uh, particular regimen or exercise or thing you did that helped more than others?
Well, different things for, I think, different diagnoses. For the lung function, I think my lung function got down to 67% at one point. So that I did lung therapy and eventually over time my lungs got better. And the pulmonologist told me every 5 years your lungs can heal. And so, that was one thing I did. The cognitive therapy did help me for um, how to try to better remember short-term things, how to note take better, how to do, your calendar, like immediately when you have a thought, like writing it down, or like even little things like when you meet somebody in your contacts, put like red shirt met at church in their contact name. So when they call or you have to message them, you can find it. Little things like that, but also I've taken a lot of NAD, and I do feel like that's helped with my energy a little bit. And I don't know. I do physical activity, and so even though it would kill me for 3 days at a time, eventually it got to 2 days, and then it got to one day, and now I can exercise regularly. So I think it's just different things, but also finding out some of the things that were wrong were so helpful, because then I could attack it one by one.
Right.
Yeah, one other question that I saw in the questions that came in from the webinar participants in advance that I thought, maybe I'd kind of pose to you, Whitney, is um, uh, someone said that they omit long COVID when seeking care because of judgment. And, is there any way to kind of get, I think the rest of the questions about the stigma that can be associated with long COVID. And I'm wondering, did you ever feel that, because you were very active in seeking out care, did you ever feel like, stigmatized because of, what you were telling, medical providers or medical teams?
Mm-hmm. Yeah, I felt embarrassed a lot. I felt isolated a lot. Um, I've, sometimes people would say, like, you're being lazy. When I wasn't lazy, I was just exhausted and I was sleeping all day. Um, so, yes, there is a stigma around it, but I did read that people affected by long COVID, it would be the eighth largest country in the world right now. And that's like an older stat, so it might be even bigger now. So I think more people have long COVID or vaccine injury than we even realize. But yeah, some doctors, and a lot that was common in my long COVID group at Vanderbilt, is that doctors would tell you there's nothing wrong with you. Or the most frustrating part was when your labs were all normal, and so they'd say, like, nothing's wrong, and so you would think you were crazy, literally, until you started meeting or talking to other people that had similar symptoms as you, or were experiencing similar things. That was extremely helpful. Um, so,
Yeah.
Yeah.
Go ahead, Jim.
I was going to say the issue of having um, normal labs. One of the things that actually has emerged out of research over the past few years is that at least many patients who had COVID infection have got reservoirs of vaccine or vaccine fragments or pieces of vaccine or virus, I mean, reservoir virus or viral fragments or something like that in their body. And it turns out it is really, really hard to see them. And so, as measures that, you would think a measure of that directly might actually tell you something as at least a diagnostic for some patients, but it's actually really hard to measure. So now people are, including my lab, moving to secondary measures, or if this is the case, then maybe this sort of thing. So it's really been looking like a needle in a haystack, and so many of our diagnostic tools are really designed to probe for acute disease, not for something chronic. Makes it very, very challenging. I think this is we're learning a lot, but it's a hard thought knowledge right now.
Yeah, and the normal labs that we have available in, a clinic or hospital, Recover did study those, a panel of like, 20 common labs that we would have thought might be deranged, um, turns out kind of stone cold normal on a population level. So a lot of the typical tests we use can be negative. So I think that's one finding, and it kind of elevates two things. One, it elevates listening to your patients and hearing what they're experiencing, and two, it elevates a call for further research for some of the advanced diagnostics that Jim's talking about.
mm-hmm.
There is going to be signal there. I mean, we actually know there is signal there. It's just really hard to turn it into something that one can use in a general fashion yet. But um, it's like when you were told um, given some specific thing to work on, it was actually much easier because then you could focus on your lungs or focus on this or that. And, that's the value of having a highly accurate diagnostics here. Without that, you're sort of, swimming in the dark. It's very tough.
Mm-hmm.
Whitney, I want to turn to the question and answer here for a minute. There's some of the participants on the webinar tonight have questions directed directly to you, and then there's some sort of general ones. So maybe we can, in the last kind of 10 plus minutes or so, try to answer some questions directly. So Here's one from one of the webinar participants. It says, question for Whitney. Do you see a difference from physical, emotional, and mental stress and the fatigue levels?
Well, that's a good question. Do I see a difference in the I don't know if I can measure that. That's a great question. I don't know if that's measurable, but yes, there are. Um, Gosh, I would have to think about that. Um, yeah, I don't know. I'm not sure. I don't know if it's measurable, but yes, I do feel kind of fatigued from all of them, just because my mental health has changed. My physical health has changed, and obviously, both of those play into your emotional health as well. So that's a really good question.
Yeah, there was a similar question also submitted in advance that tried to stress that point about the mental health diagnoses that can come along with long COVID. And I think you really covered that really nicely. I think that in general in the field, it's thought of that the anxiety and depression can result from the situation. We call that situational depression of not being able to do the things you used to do. It can also be completely, um, you know, uh, related to what you're experiencing versus pre-existing and a worsening of a pre-existing,
Mhm.
depressive syndrome. So I think there's all different flavors of the mental health diagnoses and conditions that can come along with long COVID.
Mm-hmm. And I know some people in my group did have like PTSD. There was some psychosis, and I do know, some people had suicidal thoughts, often just because of their health and not being able to get better.
Um, okay, and Jim, I'm going to be kind of looking back and forth between the Q&A and the questions advanced, but jump into if there's any that you think we should be answering, so
Well,
we can
we
kind
did
of.
talk a little bit about cycle two, and so I'll just say a few words on that. There's a question about what's the status of being enrolled in cycle two. That's the next recover study for those who participated in the first study. Um, the first study will draw exclusively from patients who participated in cycle one, but not all patients who participate in cycle one will be able to participate in cycle two. It's just a smaller study. It's much more. It's very tightly funded, and it's a 5,000 patient study instead of a 20,000 patient study with a focus on certain symptoms. And there's another question here too, which is, can Recover stop defining long COVID as a cluster of symptoms or using the 11-point score system to exclude patients from research? This is actually something that was brought up at this recent meeting in Arizona. I think Jason brought it up. And so there is physician discretion. I think I have that right? So you don't necessarily have to fall into a black and white category. There is a gray area that the physician has discretion on.
Yeah, and we should address that because there's a couple things there. I think for one, the Long COVID Research Index is a research tool for
Right.
categorizing long COVID, and it really is not perfect. I think if you have a single symptom, a lot of people in the chat have measured smell and taste disorder. So if you have that single symptom, you won't be classified as long COVID by the research index. So I think that when we redid the research index, we kind of tried to position it properly that it's a tool for categorizing the most symptomatic patients that have the kind of cluster or syndrome that like Whitney's described, um, with multiple domains affected, the mental health, the neurocognitive, the fatigue, all these different things together. But it doesn't really classify very well if you have a single symptom. So, for clinical care purposes, people should not be using the Long COVID Research Index. For research studies, it is a somewhat useful tool but needs to be drilled down further to talk about certain syndromes. So, for instance, all the clinical trials, are not using the Long COVID Research Index. They're using, really detailed questionnaires to screen people in for neurocognitive dysfunction or autonomic dysfunction. So I think the Long COVID Research Index is a tool, but it's known not to be perfect, and it's not a diagnosis of long COVID. So I think that's important to address. Just one more word on inclusion in cycle 2, and there's another question in the Q&A about people from the earliest cohorts that were excluded from recovered trials. So I think we can try to address some of these issues of study inclusion. As Jim mentioned, Recover Cycle 2 is a smaller study, so not everyone will be invited, unfortunately. There was talk at the meeting of potentially trying to do a questionnaire only, but right now that's not the study that is moving forward. The ship has been built while we're trying to sail it. So I think there's been changes throughout, and hopefully we'll be able to at least try to retain people in participating by questionnaires. But right now, you will or you won't get an invite to participate in the Cycle 2 program. And that's not going to be a decision at our hub level. It's a decision from the sort of central study who's inviting, a big group of people selected randomly, and then additionally trying to get people who have, the severe neurocognitive dysfunction, cardiopulmonary, and the chronic fatigue type symptoms. So that's who the study is going to be enriched for. And just to address the kind of the exclusion of the earliest cohorts of infected persons, actually Recover was very good on that. It did not exclude anyone who lacked a lab diagnosis or was from the earliest periods. You could be classified as probable, COVID infection and still be included in the trial. So that was not an issue with Recover, but it has been with some other trials. All right, so that's sort of what I wanted to say about inclusion, and we're happy to address further questions about this. Over email, you can message your study coordinator or communicate with us in the ways that we have. Let's see what else. Jim, is there any other questions that are jumping out at you that we should address in the last few minutes?
We've answered a number of them. There's one question here asking, I seem to have lost it, but what is the connection between long COVID and worsening or a new autoimmune disease such as lupus? So it has been in the literature an established, I would say, epidemiological connection between autoimmunity and long COVID, and so. And I think in the next year, in fact, I know in the next year and next short amount of time, there will be some genetic connections between things like lupus and other autoimmune conditions and long COVID. And so this is, those genetic connections are going to be important, but they're also going to be the kind of thing that give you a sort of a better molecular definition, at least for some of the patients suffering for long COVID, that this is of the reality of the situation. We know it exists, and it just has to get throughout the medical community. It's not a diagnostic yet, but it's a clean signature.
There was a couple questions in the questions submitted in advance about olfactory dysfunction or smell and taste disorders. So I wanted to just highlight one paper that recently came out of Recover, and I'll put it in the chat here so you can click through to that. But that was a very interesting study that showed that many people experience smell and taste dysfunction or loss of taste and smell, or some changing of their taste and smell, and others who did not notice it also experienced that being lower than normal. So the other interesting thing that was picked up in this paper in JAMA Network Open is that there may be a link between the neurocognitive symptoms and the smell and taste disorder. So I think that is something that needs to be pursued further, and to see if that's kind of a hallmark or if it tracks to earlier problems with cognition.
So I think we're at time. We will just for those of you out here, first I'm grateful for those who attended this town hall, especially for those who are patients who are members of the long COVID committee, or even folks who were in our cycle 1 recover study and want to participate in cycle 2. We do have these town halls periodically, something like once every 3 or 4 months. The science that's coming out of cycle 1 and will continue to come out with cycle 2 is coming out a little more quickly now that the biobank is complete and analyses are happening. And so I'm optimistic that over the next couple of these town halls, we'll be able to give you a little more resolution on that beyond just population type statistics and clinical observations. So that's something to look forward to. And we will probably have another one of these town halls maybe shortly before we officially open up cycle 2 to let people know what to expect. So Whitney, thank you so much. I really appreciate you coming on and sharing your story. It's a powerful story, and I thank you. That's all I can say.
Thank you so much for having me. If it helps one person, I'm just happy to share it. And yeah, we'll keep fighting this thing. So thank you so much to you and your whole teams for doing the research to help us, because without you guys, we really don't we don't know how to make it. So thank you.
Great. Thanks, Whitney. And for everyone on the town hall today, thank you for joining and for your interest. The link to the Swedish Long COVID registry is in the chat there, and we can also try to send that out afterwards. If anyone is interested in participating in interventional clinical trials, that's a great thing to sign up for, and we will get you more information through that registry. So thanks again for everyone, and we'll see you next time.
All right. Thank you all.